Hello, welcome back. So I just want to take a quick break, and this is going to be the second part of it. You notice we only got through the chief complaint HPI and like the first couple of sentences of the past medical history. So let's go into continuing on with this. So hypertension, diabetes, oh my goodness, another contributing factor. You guys know this. And then they had a surgical procedure for the acute myocardial infarction 5 years ago that was treated with cardiac cath. We did that, right? Didn't, oh, maybe I did not do it on this one. I forgot to write. So let's say your patient comes into the clinic, you administered Mona. The Mona, as we said, was not working for him. So what do you do next? Well, it depends on where you're at. If you're at Wahiwa, do you have a cath lab? You know, cath lab. So we have to figure out what to do at Wahiwa. What do we have? We have TPA, alteplase. It is also known as streptokinase. If you guys remember, streptokinase was an enzyme that was made by a fungus when they were trying to do some experiments with. It was found on accident, right? Uh, I believe it was found on accident. Don't quote me on that. So we're going to say TPA, also known as alteplase. You might not be familiar with this anymore because it's not commonly used in places that have cardiac catheters, right? Cardiac cath labs. What do you do when they get there? You suspect Mona, you've thrown them my EKG, the EKG monitor. Let's say their troponin I levels 3 times are significantly elevated. We're not going to do numbers at this point. We're going to try and get this as fast as possible going through this. On the EKG, male might present with a STEMI, right? Female might not present with a STEMI. So here's a little joke for you guys, and you guys might start seeing this in the clinic. So, ladies, men. What problems do we have? Menzies, menarche, menopause, mental breakdown. No, just joking, just joking. Okay, so what you think about with women, right? Um, we have estrogen. So estrogen creates elasticity inside of the blood vessels. So we don't experience MIs until we hit what stage, what point? Menopause. At the time of menopause, after that, you are more like a man. Why? Estrogen levels go down. That protective aspect of estrogen is gone, right? When your levels of estrogen go down, you are at greater risk of developing an MI. What is the difference between a man having an MI and a woman having an MI? Post surgical intervention recovery period, right? The years later, men survive it. Why? They've had heart attacks throughout their life. They've built something we call collateral circulation. This is a roadblock. We figured out in Hawaii that when there's a roadblock, we take back roads, right? We develop back roads. Somehow we figure out back roads to get around the roadblock. Women, we're terrible drivers sometimes. We don't know that there's back roads. So we don't ever take the back roads. So when the MI hits us, we're stuck in traffic. What do? Sometimes we stay on the freeway for hours waiting to get home. Men, they figured out. They drive around the block. So collateral circulation is a significant part of recovery period for someone who has an MI. Men will have greater collateral circulation than women will have. So women's survivability post MI, especially postmenopausal post MI, that survivability goes down only because of the fact that we don't develop this collateral circulation. So you got to take care so we don't have to manage this or just have somebody else drive, whichever one works for you. So women tend to present with non-STEMI, right? Non-ST elevation MIs. Men tend to present with STEMI, ST elevation MIs. Here we go, continuing on. So BPH, obviously it's not a woman. Benign prostatic hyperplasia, 2 years. He's probably on some kind of blood vessel dilator, which can dilate the urethra to increase flow or maximize flow, like Flomax. Hypertriglyceridemia, that is a contributing factor to the development of this plaque formation within the coronary vessels or any vessels within the body. There we go. Edematous colonic polyps. Family history, father died from MI, so significant for him having an occurrence of an MI. He also had diabetes. Mother died from breast cancer at age 79. Patient, sister, 52, alive, well, and one brother, 44, with hypertension, right? Hypertension is contributing factor. So if he's having an MI, he will probably tell his brother to watch out for his hypertension, manage that to reduce the risk of developing or having an occurrence of MI. Grandparents may have had heart disease, doesn't know. Social, oh, didn't I say this Virchow's triad? Some of the contributing factors towards clot formation were hypercoagulability. And what occurs with or what can contribute to hypercoagulability? It is smoking cigarettes. So smoking cessation is a big deal with someone who has a history or a family history of MI, because you want to reduce the occurrence of clot formation. He also might be on some kind of blood thinner, right? I say blood thinner. I know I get scolded if I use those terms without being correct about, like aspirin is an antiplatelet. Somebody told me it's a platelet aggregator. I'm like, no, it's not. It is, according to the textbooks, it's an antiplatelet, right? It could be warfarin that you use. That's an anticoagulant, right? You could be on Plavix, clopidogrel, right, which is Plavix, Eliquis, some of these other ones. But the point is, stop the coagulation by stopping the cigarette smoking. What else does he have? Married, lives with wife, 29 years, 2 grown children, no medical problems, full-time postal worker, 20 years. Before that, a baker for 8, occasional alcohol use, average 2 beers per week, never used street drugs. Review of systems, positives for some chest pain, physical activity on off for about a month. That is a sign that they should probably go in. The review for you and all of us that are in the medical field is actually a review for our family members. When we have as much time as we have to study this information, one of the things that family members don't do is listen, right? You could be saying something like, I noticed that you're having, and they will say, yeah, my doctor didn't say, or my nurse didn't say. It's like, okay, we're here in the medical field to protect our family too, right? And then when they need you, they call you. Go figure. Okay, allergies, we already said imipyridine, trimethoprim sulfate. So anything with sulfa, probably going to have a reaction too. Medications, amlodipine. Woo-hoo, you guys know this. I love medicine. Okay, so amlodipine, what is that? It's a calcium channel blocker, right? So there are, no, we're not, this is not farm. But it's farm. My goodness. Okay, so farm, not farm. We don't know, but we're going to play around with this anyway. Anyway, calcium channel blockers. I am going to provide a link because I don't have enough time to go over this, but this is super important. Calcium channel blockers, what do? Calcium for contraction. Who's its counterpart? Calcium causes contraction, increases blood vessel constriction. Constriction increases the resistance in the vessel, increases the blood pressure, right? So any kind of calcium would cause increase in blood pressure. So who's the opposite of calcium? You guys know this. I know you guys use this in the hospital. Mag sulf, right? Magnesium sulfate. Magnesium is the counter to calcium. Calcium causes contraction. Magnesium causes relaxation because it has an opposing effect to calcium. Calcium contraction. So if I block calcium, I can block contraction. If I block contraction, I can cause the radius of a blood vessel to dilate, resistance to go down, blood pressure to go down, and that's how it can help to work. It can also slow the conduction in the heart and therefore reduce transmission of a signal within the heart, slow heart rate, and can be used for someone that has maybe transmission difficulties, like with, let's say, I'm going to say with AFib, but there's other things, so we're not going to go on that yet. Glyburide, what's that for? That's for his diabetes. Aspirin, oh, he is on aspirin, but the dosing is a little bit high. You would think it would be baby aspirin, 81 milligrams. I don't know if maybe that's a typo. Damfibrazole is for the cholesterol, right? Sulfasalazine is for his, come on, people. It is for his ulcerative colitis, right? He had a past medical history of ulcerative colitis, 22 years. And then terazosin, what is terazosin? I know you guys haven't seen this, but I know that I required you to go over the autonomic nervous system. And the autonomic nervous system, Zosyn, and not the brand name Zosyn, as in Zolson used for infection. This is a different Zosyn, Z-O-S-I-N, not Z-O-S-Y-N. Z-O-S-I-N is an alpha 1 blocker. So alpha 1 causes vasoconstriction. If I block vasoconstriction, then what happens to blood pressure? So a side effect of terazosin, tamsulosin, any of the zosins, that suffix, is that blood pressure will lower. So it can actually help someone who has hypertension. But it is actually used, in this case, it's actually used to treat BPH. Why? They have flow difficulties, right? Their urine doesn't come out as well because there's an obstruction. So it causes alpha 1 block causes dilation of the urethra. So that allows for increase or maximizing flow of urine. Here we go, physical exam. You guys can do this. Alert oriented, appears state at age, anxious, appears to be in severe. This one, vital signs. No, that's not the one I want. I like lab values, but here we go. Blood pressure, 190, 160 over 98. Review of blood pressures. I know you guys already know this. This is why I talk as fast as I do, so I can go quickly through this information. And I assume that you guys have already had this at some point in your life. So 120 over 80, it's actually less than 120 over 80, right? And then all I do is 20s over 10s, right? Add 20s, add 10s, and that gives you the staging. So 140 over 90 is stage 1. What stage 2? 160 over 100. It used to be at some point, I think we had a discussion on stage 3, but we just call that anything above 160 over 100. Yeah, let's push them in somehow into the hospital, right? So my mother-in-law had like 231 over 119, and ooh, that's like right in my forehead. 231 over 119. She was in she was in the doctor's office, and the doctor was like, "We're gonna admit you to the hospital. This is ridiculously high." And she's like, "No, no, no." So she left. So with a blood pressure like that, yeah, a little bit stubborn. So stage 3 could have been 180 over 110, but we don't have that for staging, so we're gonna cross that out. But easy way to remember: 20s over 10s. Anything in between here, you guys already know, is pre-hypertension. Sorry if this is a little bit boring for you guys because you guys already know this, but that's a good sign. Okay, respiratory rate, that's normal, 510, right? Temperature, 98.2, so afebrile. Weight, you guys can calculate BMI if you want to, 105. So this is definitely an irregularity, right? What is that? If there is no signs of um, abnormality in the EKG, right? Everything looks normal. I'm not going to assume that, I'm going to assume that you guys already all know this. So it's normal sinus rhythm, but it's not. It's sinus tach, right? Because it's greater than 100. Moving on, skin, cool, diaphoretic, that's what you expect in someone who's having an MI. Supple, no thyromegaly. So you worry that this might be causing this, but there's no thyromegaly, no adenopathy, no bruits, no jugular venous distension. So JVD, as a review, JVD is when we get to congestive heart failure, it's a sign of right-sided heart failure, which could be secondary to left-sided heart failure. So hint, headaches, ears, nose, throat, somatic membranes clear. I'm just kind of skimming through this. You guys can skim through it with me if we see anything that stands out a little bit. So we said already normal S1, S2, no S3, S4. So S3, S4 would be, we're not diagnosing. I know RNs don't do that. Maybe later on when you become a nurse practitioner, you might get into S3, S4. S3, S4 abnormal sounds. S4, I just remember more force. So it's usually going to be in someone that has cardiomegaly, right? Enlarged or thickness of the walls in the heart. What about S3? S3, a lot of times I think or remember hypertrophic cardiomyopathies where there's over distension, over dilation because of fluid volume overload. The walls are thin, it's pretty weak. Abdominal, nothing positive for that. You want to be negative for bruits or organomegaly. Bruits, why? Because you want to rule out a abdominal aortic aneurysm. Then we move on to musculoskeletal. You guys can do this. Neurologic is intact. Negative Babinski, which means you don't have any kind of CNS deficit. Lab values, yay! This is all the fun. This is all the stuff that you guys You guys already know you're gonna outdo me, and that's okay. I love this stuff. I'm still learning, right? So your favorite, I'm sure you guys all do your favorite, and I do. On the hospital, I've been drawing it like that because it's just faster, right? Um, oh, it's like all the typical go-tos for telemetry, right? Mag, Cals, um, phosphate. I don't know why I was writing sulf, phosphate, some other stuff. We can write ABGs later, but let's do like the simplicity of this, right? So we have sodium 133. Then we have 4.3. So do you guys see anything that stands out? BUN, bicarb 22 within normal range, BUN. So what I want to remind you is this textbook had lab values and I downloaded it at first, but it was a little bit outside of the numbers that I normally see. And even I think you guys would have memorized for the NCLEX. So I took it away so you guys can use other resources that you might have. Hospitals are going to be variable in their numbers, but it's only slightly off, right? Um, I think I'm going to assume that you guys use this. So we're just going to go over, right? Sodium, potassium, chloride was like 101. This was like 22. Bu and creatinine, significant. Was it significant for kidney disease? No. Fasting, glucose, 264. High, not high. Highs, but we already know he has diabetes, and then under the stress, he could be releasing more sugar. So we can manage him with that. Mag, phosphate, cholesterol, that's high, right? There we go. Troponins, zero point 0.3. It's supposed to be 0.05, right? So it is 0.3, and it's not showing 3 values. Hemoglobin, hematocrit, that one looks fine. He doesn't look like he has any kind of infection. Platelet count is normal. Hemoglobin A1C is high, but we already know he's diabetic. He's probably uncontrolled, has not been watching his diet. So arterial blood gases, you guys remember this, right? ABGs. If I try to fill this in, you guys are getting bored with me. So we're not going to fill this in. I'm going to make you guys fill it in on your own, but you already know like the format. So when you're doing this, go ahead and fill it in. Look for any abnormalities. And on discussions, when we try and get through discussions, you can point out things that I might have missed on my videos. Here we go. pH 7.35, 7.45, so within normal range. PO2 is 90 millimeters mercury, 96.5% O2 sat. Obviously, it's a little bit down because he's having issues with breathing and, well, not the breathing part, but the anxiety, the diaphoresis, all the associated symptoms. This would probably be a little bit lower. PCO2. So what are we looking for? Sometimes you might be looking for lactic acid, right? So lactic acid would cause the pH to go down. Maybe you might have somebody who's hyperventilating. Maybe you're worried that this person, because he has a history of diabetes, doesn't say diabetes type 1 or 2. So if he's type 1, maybe it's a history of DKA you're worried about, right? Lactic acid buildup, Kussmaul's breathing, or Kussmaul's. And then ST elevation, right? So he has a ST elevation or STEMI. Mild pulmonary edema. Why would he have mild pulmonary edema? That's the thing that I want to get to. So we've covered a lot of information, and I realize that this is the first one. I'll probably go a little bit faster in the future case studies because this is a little bit too long for me. I like to keep it as short as possible. So here we go. Here's the heart. Here's the body. This is the 4 chambers of the heart. Here's the lungs. So heart, body goes to the right atrium. From the right ventricle, it goes to the lungs. From the lungs, it goes to the left atrium. For the left ventricle, it goes back to the body. I have videos in this so you guys can look through it. But let's say that somebody has an MI of the anterior leads, right? So anterior leads, so let's say that there's an assumption that the LAD, or left anterior descending coronary artery, is occluded. So I have left ventricular dysfunction, LV, let's just go left ventricular dysfunction. So I have that. What happens to the blood? Blood will flow back into the heart. Excuse me. So blood will flow back into the lungs. That will increase the fluid in the lungs. That's also known as pulmonary edema, right? Or effusions or pleural effusion. However they name it, just means water in the lung, right? So bilateral mild pulmonary edema without pleural disease or widening of the mediastinum. Clinical course, so this is the last of it, really quick. Patient history showed no contraindications to thrombolysis. So do you think this hospital that we're at has a cardiac cath lab, or do you think they are going to go with TPA? Based on the reading, it sounds like they're probably going to go with TPA. What are the rules for that? We said the patient came in 30 minutes after the onset of symptoms. How many hours do you have when they talk about stroke? Depends on the hospital. They basically will tell you within or less to or equal 4 hours from the time of onset of a stroke, right? You come in and they will give you, well, we're not going to talk about stroke ruling out and all the diagnostic tools. We're on MI, so forgive me for bypassing all of that stuff. So within 4 hours, they can give you TPA. So the reason they put 30 minutes is because they want to say by the time they got to the hospital, the clinical course suggested that they use TPA because they probably don't have a cath lab at this hospital. So now, patient received IV Retiplase, which is Altiplase, IV heparin, right, which is your anticoagulant, metoprolol. Why metoprolol? So we are going to go over this because this is a part of the case study, right? Increased oxygen demand causes the heart to what? Contract faster. Didn't we say that he's in sinus tachycardia? Sinus tachycardia, increased contraction of the heart, causes what? More oxygen demand, right? More depletion of oxygen available to the heart. So what do I do for the heart? I give a beta blocker. Boom. Slow the heart rate down. I decrease the oxygen demand because there is a lack of oxygen supply because of the occlusion of the blood vessel. Isn't this fun? I told you it would be fun. So here we go. Approximately 90 minutes after, oh, and then lisinopril is your ACE inhibitor, right? Approximately 90 minutes after initiation of Retiplase therapy, patient's chest pain and ST segment elevations had resolved, and both heart rate and blood pressure normalized. Patient was stable until 2 days after admission when he began to experience chest pain again. Emergency angiography revealed a 90% obstruction in the left anterior descending coronary arteries. Woohoo! Based on the information that we just talked about, this is pathophys. You can predict what's going to come about. You can predict a lot of things if you go back to your physiology and your pathophys. So we already said 2 days later, emergency angiography revealed 95% obstruction in the LAD, as we just said. No additional myocardium was at risk, consistent with single vessel coronary artery disease. Completed MI. Percutaneous transluminal coronary angioplasty. What is that? That is just your cath lab, right? You're putting in a stent. So they went up for exploration. They probably put in some kind of stent, and now he's going to be on Plavix forever to manage the clot formation and prevent it from damaging or occluding at the stent. So now I have successful putting in a stent. After a stent was placed, put on abciximab infusion. Instead of Plavix, they put abciximab, right? Anticoagulant therapy. Ejection fraction by echo 3 days post-MI was 50%. Okay, so we know echo, right? TEE, transesophageal echo, is they use that to cardiovert, right? They're looking for clots. If you find a clot, you can't cardiovert. This is in a patient with AFib. How would we use it in this patient, right? So the echo itself, as they're monitoring, the echo itself can tell you ejection fraction, the performance of the heart. And you guys know it should be greater than, right, 50%. Should be greater than 50%. At 50%, you're worried about future implications, right, and pushing into congestive heart failure, right, or some kind of heart failure. So he had 99.5. Maybe he's starting to have an infection. Remainder of patient's hospital stay, unremarkable, gradually ambulated. Physical activity was slowly increased. Discharged 8 days post AMI. And that's it. Yay!